So we'll move on to the next topic on novel therapies in cardiac amyloidosis, and there's been a lot of recent advancements and changes. My partner, Barry Trachtenberg, who's the director for the cardio-oncology program and oversees our amyloid transplant, I think will give us an update on the recent novel therapies.
Thank you very much. It's a pleasure to be here. And today we'll talk about some new therapies for amyloidosis. It's an exciting time in this field. I do have disclosures relative to this talk, which are the following up here. So starting with the case, the first case, it's a 70-year-old African-American man with a history of cardiomyopathy with an EF that's in the 40 to 40% range. He did have a prior stent in his left circumflex artery about 10 years prior to presentation and persistent atrial fibrillation. He was transferred here for advanced heart failure evaluation due to multiple heart failure admissions. He has no family medical history that was pertinent. His past surgical history includes a history of carpal tunnel release 8 years prior to presentation. So we started with an echo after his physical exam, of course, which didn't reveal the diagnosis, but he had a thick, you can see thick left ventricular walls here. You can see relatively preserved ejection fraction, but still mildly depressed. And you can appreciate here in the subcostal view that he also has a moderate degree of right ventricular hypertrophy. In addition, he does have large biatrial enlargement. So this is an amyloid talk. We obviously don't need to guess at the diagnosis in general. But immediately after seeing that echo, we thought that he probably has amyloidosis, given his history and the echo. And so we did our initial evaluation. Our initial evaluation includes looking at the free light chain assay of kappa and lambda light chains for systemic AL amyloidosis. And you look at both the number of kappa and lambda light chains and the ratio of them. And this is a normal ratio, meaning that there's not one light chain that predominates, which you might see with systemic AL amyloidosis. We had immunofixation and SPEP, UPEP were done. Those were normal. And then we went on to a technetium pyrophosphate scan. How many in the audience know what that is, for show of hands? Okay. So it's a pretty old therapy that's being revised for this diagnosis. So he had a technetium pyrophosphate scan, and basically this, for unclear reasons why this happens in the heart, but the heart will uptake, for transthyretin amyloidosis in particular, will uptake the agent in the heart, but not the mediastinum. So you see a ratio in the heart. This is a positive scan. So the ratio of uptake in the heart compared to the mediastinum greater than 1.5. So if you're considering amyloid and you have a negative light chain assay, then this would be very positive and would be highly sensitive and highly specific for transthyretin amyloidosis, which we'll talk about what that means in a moment. And a negative scan or less than 1.5 suggests that TTR amyloidosis is not present. This patient had a positive scan. It was greater than 1.5, and we went on to make the diagnosis of transthyretin amyloidosis, but we weren't done there. So there's two main types of cardiac amyloidosis, as I alluded to. The first is light chain amyloidosis. This is a disease in the bone marrow where you have plasma cells produce light chains that become misfolded and they aggregate and they form amyloid fibrils. And amyloid fibrils are not able to be absorbed. They get deposited in the heart, obviously. That's what we're talking about. But in the systemic amyloidosis, it can get deposited in almost any organ, in the kidneys and the nervous system and throughout the body. And the other major type is transthyretin amyloidosis. That's where we'll spend the majority of time talking about today in the light of new therapies in this field. And for transthyretin amyloidosis, there's two types. There's the hereditary type, and then there's what we call the wild type. It used to be called the senile type because it's common in patients that are elderly. So in the transthyretin type, transthyretin, it's a protein that's made in the liver predominantly, and it's involved in the transport of thyroxine and retinol. And it forms these tetramers. These tetramers, if they get unstable due to either a mutation or the wild type variant, then they break down into monomers. these monomers aggregate and form these amyloid fibers as well, and these fibrils get deposited predominantly in the heart or nervous system, depending on the mutation. Can we go forward? So basically, this just shows additionally in more detail the transthyretin pathophysiology, and we can go on to the next slide. So the specific mutations really influence the phenotype. So for TTR, there's over 120 mutations, and which mutation you have tips the balance to whether you have a primary cardiac phenotype versus primary neurological phenotype. And there's overlap. Everyone that's over here and everyone that's over here still has, up to 10 to 20% of patients will have a phenotype in the other arena. So, for example, this is the VAL 122 isoleucine mutation, now called the 142 isoleucine mutation. This is the most common cause of TTR, hereditary TTR in the United States. This is actually very prevalent. 3 to 4% of African Americans in this country have this mutation. That doesn't mean that 3 to 4% of African Americans have the disease. There's incomplete penetrance, meaning that if you have the gene, you don't necessarily get the disease, and we don't really know what the degree of penetrance is, but there is a large amount of our population that's certainly at risk for this disease, and which is under-recognized, and we're just now discovering, now that we have techniques such as the pyrophosphate scan, which doesn't require a biopsy to make the diagnosis. We have genetic testing available. We're able to recognize the disease more often. This, the VAL30 MET mutation, this is the early onset variation, is primarily a neurological disease with really incredibly disruptive quality of life in terms of neuropathy. And this is very common in Portugal, for example. The late onset variation has more overlap in terms of the cardiac phenotype as well. And I just want to note there are 2 companies now that are offering free genetic testing for TTR, so there's no barrier in terms of getting the genetic testing for your patient in terms of financial. This is a nice slide that really shows you some of the red flags that when you should think about cardiac amyloidosis. So if you have an echo that shows that the LV is thick, the walls are thick, but your EKG shows low voltage, it's not congruous. You'll have, the voltage does not suggest left ventricular hypertrophy on your EKG, but your echo, you clearly see that your walls are thick, and your walls are thick because you have all these amyloid deposits in the wall, not because it's responding to pressure overload and having true hypertrophy. Other red flags are patients that are intolerant to traditional medications such as beta blockers or ACE inhibitors, patients that have a low normal blood pressure and previously had a history of hypertension, although frankly that does apply to a lot of advanced heart failure patients as well. And then patients that have bilateral carpal tunnel syndrome, often requiring surgery. Oftentimes these patients will say, yes, I was a typist or I was a machinist, and they'll blame it on that, but really it's fairly prevalent. There's been 3 or 4 studies now that have shown in single-centered populations that up to about 10% of patients that are referred for carpal tunnel release, if they do biopsy on the tenosynovial tissue from the surgery, 10% will have amyloidosis. So it is something that if you see patients with bilateral carpal tunnel syndrome, that it should at least, obviously not all of these patients will have amyloid, but at least you should think about whether they have any of these other red flags to suggest the possibility of amyloid. So when you think about systemic amyloid or AL amyloid, light chain, you also think about the kidneys and nephrotic syndrome. These patients will often have macroglossia, so an enlarged tongue, that we call the raccoon eyes with the periorbital purpura is common, orthostatic hypotension, and then peripheral neuropathy. I mean, this frankly should be up here because this applies to both variants of amyloid and MGUS as well. For transthyretin amyloidosis, some additional red flags for a white male with over 60 with a history of HFpEF and a history of carpal tunnel syndrome or spinal stenosis is also a frequent symptom in these patients as well. And then for the African American population with a history of HFpEF in a patient over 60 without a history of hypertension should be a red flag to consider it. And additionally, we're finding in patients with hypertrophic cardiomyopathy, that's a new diagnosis as we age, also patients with low flow, low gradient aortic stenosis. They've looked at patients referred for TAVR, and depending on the study, anywhere from 10 to 15% of those patients might really have TTR amyloidosis because they have thick walls that suggest that they have aortic stenosis with pressure overload. But in reality, it's really TTR amyloidosis. And of course, anyone with a family history of hereditary amyloidosis that is an autosomal dominant disease, so that's someone that should be screened potentially for TTR. So getting to the exciting part, for the history of this disease, we've had no therapies that have been proven to make any meaningful difference. And now in the past year, there's been 3 new drugs, all in the New England Journal of Medicine in the last year, that have shown a difference in this disease. And we'll talk about what their indications are and for which patient population they're indicated presently. So this is a review looking at the normal synthesis, mutant or wild type TTR production, and it creates RNA that's available for translation and to make the protein. And so now there's 2 therapies that are out that have attacked the RNA to prevent or decrease the production of the TTR. And so I just want to note that these both work. So the first one, inotersen, the second one, patisiran. These both can target both wild type and hereditary TTR. We'll talk about the studies, and because of the studies, they're both only indicated now for the hereditary form because that's what the studies looked at. But either way, both these agents act in a slightly different way, but they both will decrease your transcription of the RNA to make the protein. And the third therapy is what we call a stabilizer. The third therapy is tafamidis is the third agent. And what happens is when you form these tetramers and you have a mutated form or a wild type form, it causes this to be unstable and more likely to dissociate into monomers, and the monomers are what end up forming the amyloid fibrils. If you're able to prevent this dissociation and keep this as a tetramer, then you're able to improve the disease. So looking first at tafamidis, this is the most recent of the 3 in terms of the publications. It is currently under review by FDA, so it's not available for use at this time commercially, but is expected to be available in the near future. So this was an article that came out just a few months ago. And this, unlike the other trials, this included all types of patients with TTR, whether they were wild type or the hereditary type. So looking at this, and they looked at mortality at 30 months. And you can see the curves are pretty similar. Up until about 18 months, they separate. But by 30 months, there was a 30% reduction in mortality in all comers. And looking at the subgroup analysis, this was independent of whether it was wild type or mutant type. And they had 2 different doses, so they looked at both doses combined, and the pooled doses showed that it was better. And whether it was the 80 milligram dose seemed to maybe be a little bit better, but either dose seemed to be better than placebo. The one area where there doesn't seem to be as much, it's an area of interest, it's a subgroup analysis, so it's the class 3 heart failure patients didn't do as well as the class 1 or 2. No surprise there, but it seemed to be less effective in those patients perhaps. But that to really prove that, we'll need to have another study targeted in that population. But this study included all comers, and it was a positive trial. So I would still use it in that population, maybe more cautiously, but still use it in the absence of any other therapies. So looking at the RNA therapies, these both came out side by side in the same publication in New England Journal in July of this past year. The first one, patisiran, they randomized patients with only the hereditary TTR type, and this was predominantly for the treatment of polyneuropathy. That was the target of this initial trial. And the mechanism of delivery is IV delivery every 3 weeks. And the primary endpoint, so this is not a cardiac study, this is a neuropathic study. The primary endpoint was improvement in the modified neuropathy impairment score, the MNIS. And you can see that not only did it decrease the serum transthyretin levels compared to placebo, but it had an improvement in both the MNIS score and the Norfolk quality of life for diabetic neuropathy score. And then looking at the safety profile in terms of cardiac failure and heart failure events, they were pretty similar. If you look at the cause, there were the deaths in both groups. So remember, this is a 2-to-1 treatment arm. So there's 7 deaths here, but there's twice as many patients, 6 deaths here. So similar number of deaths in each group. There seemed to be a few more cardiac deaths in this group, but these patients all had cardiac disease. So whether that's, it's unlikely mechanistically to be related to the drug, but we don't know about the cardiac specific safety in that trial. But there was a sub-study of this group where they took patients that had LV wall thickness greater than 13 millimeters and no history of hypertension or aortic stenosis to explain that. So and this was about 56% of the original trial group. And they assumed that these patients had a TTR amyloidosis involvement. And looking at this group in particular, they looked at the BNP and the LV remodeling as their main endpoints. And you can see the BNP was markedly improved. The LV wall thickness was improved. So this is a change in LV wall thickness. This is the cardiac output and the left ventricular end diastolic volume. These were all improved in the patisiran group. So this is very encouraging and hopefully will be the basis for a cardiac specific trial. The second RNA agent is inotersen. So this was also randomized patients with hereditary TTR and not with wild-type TTR, and also looked at polyneuropathy as their primary endpoint as well as quality of life. And similarly, it did have an improvement in quality in the quality of life score. This is a better score. This is a worse score, and it improved the MNIS as well. Looking at the safety profile for this drug, there were the things to note are that there was a significant incidence of glomerulonephritis and thrombocytopenia that they were noted during the trial. So during the trial, they started to monitor that more closely. So that's something to be aware about. This is a sub-Q delivery once a week. So on the one hand, it's patients can get it at home, but they do have to monitor their CBC and their creatinine once a week. There's a program that makes it easy for them to do it at home, but nevertheless, they do need to have blood work every week. And there were 5 deaths in the treatment group, and again, note that there's 2-to-1 in terms of the enrollment. So moving just to briefly touch about AL amyloidosis, and I know that the focus of this really is on the new treatments of TTR, but just to be aware that there are it's relatively new chemotherapies such as proteasome inhibitors that have really had a dramatic improvement in the survival of patients with systemic amyloidosis. So you can see this is a trial that looked at patients that were on bortezomib, which is a Velcade, a proteasome inhibitor, and the survival in these patients, despite having cardiac AL amyloidosis, was much improved. Now there's newer agents such as daratumumab that look promising as well. So there's a lot of improvement in patients, whether you have AL or TTR, in terms of having good options for these medications. Just looking about our experience for patients that are too sick for these therapies and are really advanced and need heart transplant, we've done 28 transplants so far. 9 of these are in transthyretin. The rest are in AL amyloidosis patients. And we've had good success in these patients. These are patients that are very sick. But if you compare our outcomes of these patients post-transplant to our other patients that get transplant for any other indication, they compare favorably. We have a 75% survival for our amyloid patients that have reached 5 years. And we're happy to be able to offer this as one of the larger amyloid programs in the nation. So just to conclude, cardiac amyloidosis, especially TTR amyloidosis, is a very under-recognized disease, and hopefully that's changing as we have new techniques that can diagnose it, such as nuclear imaging without having to do a biopsy, as well as genetic testing available for all. Novel therapies for TTR are here. We have 2 TTR silencers that we reviewed that are indicated and currently FDA approved for neuropathy associated with hereditary TTR, and we look forward to trials with these medications for patients with cardiomyopathy. And we do have 1 TTR stabilizer, that's TAFAMADIS, which is an oral pill, currently pending FDA approval for cardiac amyloidosis, whether it's due to hereditary or wild-type TTR. New chemotherapies have improved survival in patients with AL amyloidosis that have cardiac involvement. And finally, for those that are more advanced, heart and multi-organ heart transplant is an option for selected patients, and their outcomes are equal in modern era compared to other patients that undergo transplantation. With that, I thank you for your attention and will be available for any questions.